Can you see my screen or at the moment?
Yeah, very well. Thank you very much.
Okay, hi everyone. Thanks for the introduction, Joseph. Can see there's lots of people here, which is great. I'm going to be talking to you about medications used in heart failure with reduced ejection fraction. If anybody has any questions or wants to interrupt, please feel free either raising your hand or writing in the chat. Joseph, if you could check the chat and see if anyone's got questions as we go through, that would be great.
Thank you.
So we'll just, I think it'll be 20 minutes or so, and then we'll have some time for questions. Right. Most of my talk today is based on the European Society of Cardiology guidelines from 2021. If you haven't had a chance to read these, or if you're particularly interested in cardiology, I would suggest you have a read of these guidelines. They're very comprehensive and will cover parts of the talk that I haven't been able to speak about. Heart failure, the objectives of this talk are mainly to define what heart failure with reduced ejection fraction is, discuss the main pillars of treatment, and it would be useful to understand the contraindications and cautions of treatment. So when you see people as part of your training as Foundation Year 2 doctors, you'll know which patients you should possibly avoid starting certain medications for. So very simple objectives and hopefully quite a straightforward talk. So what is heart failure with reduced ejection fraction? We have changed the terminology multiple times with regards to defining, heart failure with reduced ejection fraction. If we stick with these definitions for the time being, so it's anything with an ejection fraction less than 40%. You also have something called heart failure with mildly reduced ejection fraction, which is defined between 41 and 49. And if you have preserved ejection fraction, your ejection fraction is more than 50%. So if you keep an eye out for the ejection fractions on the echo reports, I think people in most centres should be reporting, ejection fractions with a range of, between 5%. So it depends which trust you work in. I think certain hospitals in West Yorkshire may not do that, but the majority should be doing that. We need to remember that heart failure is not just ejection fraction, but is also clinical signs of heart failure. So you need to have symptoms and signs as part of that definition. The diagnostic algorithm, when you suspect somebody has heart failure, obviously it includes symptoms and signs and basic investigations, which include an ECG, NT-proBNP, and an echocardiogram. And then once you've had those preliminary investigations done, you should be thinking about what the phenotype of the heart failure is and what you think the etiology of the heart failure is. And that is usually involves a cardiac MRI scan, which will help you to investigate that in more detail. The ESC guidelines recommend the 4 pillars of heart failure as pharmacological treatments for these patients. So level 1 class evidence for all of these. So ACE inhibitors, beta blockers, MRAs, and then dapagliflozin or empagliflozin, and then a 1B recommendation for a new tablet called, I say new, it's not really new, sacubitril valsartan. So those are the pillars of heart failure. It's important to distinguish between acute heart failure and chronic heart failure. I'm sure you'll all be seeing a combination of both of these, but probably when you're on call, you'll be asked to see more acute heart failure patients. So those that present with an acute flare or a first presentation of heart failure. When you see these patients, you need to be thinking about, what's the cause of this acute decompensation. And there is quite a useful acronym from the European Society of Cardiology, CHAMPIT. So you want to think, is this an acute coronary syndrome, Could this be a hypertensive emergency? Is there an arrhythmia that's precipitated this? So, for example, VT, AF, atrial arrhythmias. Is there a mechanical cause? Could this be pulmonary embolism, an infection, or cardiac tamponade? And then depending on the cause of that, obviously will determine how you treat the heart failure slightly differently. But usually the mainstay includes identifying if there is hypoperfusion on board, in which case you may need to think about things like inotropes escalating to your seniors for consideration of vasopressors, and obviously diuretic treatment if there is congestion. And then if there's suggestion of persistent hyperperfusion or organ damage, multi-organ failure, you want to think about things like mechanical support therapy, renal replacement therapy. And obviously these discussions occur at a higher level, and you need to be involving your seniors early on in those kind of discussions. NICE guidelines have some reasonable flow charts regarding the management of heart failure. And, you know, how you diagnose or manage chronic heart failure depends on whether it's heart failure with reduced ejection fraction or preserved ejection fraction. And as we've mentioned earlier, the way that this is treated involves the pillars of heart failure, including ACE inhibitors, beta blockers, MRAs. And then you'll find that there are slight discrepancies in the guidelines between, for example, NICE and the European Society of Cardiology for starting certain treatments. For example, sacubitril valsartan in the NICE guidelines, it says you should start it if the ejection fraction is less than 35%, whereas in the ESC guidelines, you can start it if you remain symptomatic, even with a higher ejection fraction. The treatment of heart failure with reduced ejection fraction has really kicked off really in the last few years. We've had so many new trials with a number of new treatments that have been available. So we've had Paradigm Heart Failure, for example, which is one of the pioneering heart failure trials in the last 10 years or so. Sorry, let's go back. That looked at angiotensin receptor neprilysin inhibitor, so sacubitril valsartan or Entresto. And since then, there've been a number of other pioneering heart failure trials, particularly DAPA-HF and Emperor Reduced, which are both trials in heart failure patients looking at SGLT2 inhibitors. And it's because of those trials that we have changed the ESC guidelines and other cardiology guidelines. The reason that we give all these drugs, I'd say divided into three main reasons. So one, we want to reduce mortality of patients. We want to prevent recurrent hospitalizations due to worsening heart failure. We want to improve the clinical status and functional capacity of these patients and also improve the quality of life. So that's the reason why we give all these medications. As I spoke to you all about before, these are the four pillars of heart failure. So angiotensin receptor neprilysin inhibitors, Entresto, beta blockers, MRAs, so that's spironolactone or eplerenone, and SGLT2 inhibitors, which is kind of the new kid on the block, really. So dapagliflozin, for example. And there's been a lot of talk amongst cardiologists as to the right way to instigate these four pillars. Which, tablet do you start with? Or should you start, multiple medications in conjunction? And the evidence suggests now that you should probably start a number of medications at low dose, at the same time, rather than start with a beta blocker, up titrate, then add in an ACE inhibitor, up titrate, then add an MRA in. So what you should really be doing is starting low dose of all these tablets, or as many as you can, given the treatment limitations you have. And we'll talk a little bit about you know, things to look out for when you're starting these treatments shortly. So beta blockers, lots and lots of trials that show that they are good in heart failure. They reduce mortality and morbidity. And these have all been going on since the early 90s. So we know beta blockers work. The beta blockers that have been used in these trials are usually either carvedilol, metoprolol, nebivolol, or bisoprolol. So any of these beta blockers can be used and they're effective. Now, there are some sort of contraindications or, for example, cautions to using beta blockers. At this stage, I'll just pause and see if anybody from the chat can think of any reasons why you may not want to start a beta blocker in a patient with heart failure, or if they have, or any contraindications that you can think of. Asthma, yeah, bradycardia, asthma. So yeah, so so I think obviously bradycardia. I think I would go further to say high degree AV block. If you have a sinus bradycardia, you know, yes, you should be cautious with starting beta blockers. But you can still do that. But if you have a high degree AV block, then you should be more cautious with that. Asthma is not an absolute contraindication to beta blocker therapy, but if you have brittle asthma, then you need to be careful about instigating that for sure. And sometimes what you can do is you can give a short-acting beta blocker, something like metoprolol, and then check the peak flow before and after giving it, and then that'll give you an indication of, you know, how well tolerated the beta blocker is, rather than starting with a beta blocker with a long half-life, for example. I'll come back to this slide. So we've talked about high degree AV block. We've talked about asthma as a relative contraindication. And then critical limb ischemia is a contraindication that sometimes people forget. And then obviously if you have an allergic reaction or a drug reaction. It's important, and sometimes people forget that if you have sort of severe heart failure, so NYHA class 4 heart failure, or if you're in acute cardiogenic shock pulmonary edema, you definitely should not be starting a beta blocker. That is something that can really push you over the edge. If you have persistent congestion, or if you're hypotensive, that's another reason not to give a beta blocker. So if you're not sure, ask. But like you've all said, you know, those are the relative contraindications and cautions. People ask why, but how do beta blockers work? And the truth is we don't know. Some postulations or suggestions of how they might work is antagonism of the catecholamine surge, which can happen in heart failure, upregulation of myocardial beta receptors and restoring their function, which can increase the inotropic reserve of the heart. Other suggested mechanisms include suppression of the neurohormonal system, so the renin-angiotensin-aldosterone system, and prolongation of the diastolic phase, which can improve coronary flow and improve heart failure. We know that beta blockers reduce heart rate and blood pressure, and they reduce the burden of arrhythmia with anti-ischemic effects. And as I said, you need to be sure that when you start them, the patient's ideally euvolemic. You start at low dose and then up titrate. So ACE inhibitors, the second pillar. So as I've mentioned before, they improve mortality, morbidity, they reduce heart failure, hospitalizations, improve symptoms, and they also improve quality of life. The way the ACE inhibitors work in heart failure patients is probably due to downregulation of the renin-angiotensin-aldosterone system, which is upregulated and involved in the pathogenesis of heart failure. If I just once again stop to ask if what people think are reasons not to give an ACE inhibitor. I know I've mentioned a couple here on this slide. But does anybody have any other suggestions of why you shouldn't be giving somebody an ACE inhibitor? Okay, silence something on the chat at the moment, but previous angioedema, Chris, yeah, so that's good. That Chris has recognized that angioedema can occur with ACE inhibitors, and that's correct. That is a absolute contraindication to giving an ACE inhibitor if somebody's had angioedema in the past. I've also mentioned here rise in urea creatinine is expected after starting an ACE inhibitor. So sometimes people panic when you start an ACE inhibitor and your creatinine goes up. And the ESC guidelines say that you can accept an increase in your creatinine of up to 50% above baseline, or sort of a GFR up to 25 mils per minute. So that might be sort of a higher threshold than you're probably used to. And I think most cardiologists will be a little bit cautious about a creatinine rise up to 50%. I think most of them accept maybe 30%. But this is this is something to think about. Joseph has also put allergy, correct? Of course, that is another reason not to give an ACE inhibitor. And so I think we covered some of those. Don't forget pregnant women, or if you're at risk of pregnancy. Unfortunately, heart failure is not just confined to the elderly. We do see young people with heart failure. And if you're starting a ACE inhibitor and somebody who's at childbearing age, you should counsel them on the side effects of ACE inhibitors. If you're on ACE inhibitor, you shouldn't be trying to get pregnant. And if you do want to get pregnant, ideally you need to be off that ACE inhibitor. And bilateral renal artery stenosis, that's another one that people forget. So that's an absolute contraindication. And we talked about sort of hypotension as well as significant hyperkalemia and significant renal dysfunction as a reason not to give an ACE inhibitor. So moving on to Entresto, or angiotensin receptor neprilysin inhibitors. So as I said, there is a little discrepancy between the NICE guidelines and the ESC guidelines. But ESC say if you're symptomatic despite optimal treatment, then you should give Entresto. Whereas NICE say your ejection fraction needs to be from less than 35%. In terms of contraindications to ARNIs, so like similar to ACE inhibitors, angioedema, renal artery stenosis, pregnancy, allergy, and then if your GFR is less than 30. And also, we need to remember that hypotension is an important symptom or clinical sign to look out for. So if your blood pressure is less than 90, it's unlikely that you're going to be able to tolerate this, and I wouldn't be recommending starting it in those patients. And then paradigm heart failure, which I told you was the main heart failure trial that revolutionized the use of these drugs, enrolled patients with the blood pressure more than 95 systolic. The other thing to mention, if you're going to stop an ACE inhibitor and give an ARNI, you need a washout period of at least 36 hours. The next heart failure pillar, so the MRAs, spironolactone or pleuronine. So you add those in addition to the ACE inhibitors and beta blockers to reduce mortality and the risk of heart failure hospitalization and improve symptoms. And similar to the ACE inhibitors and ARNIs, we think they work by downregulation of the renin, angiotensin, aldosterone system. Just a note, a pleuronine is less likely to cause gynecomastia than spironolactone. So if you have a patient that's suffering with that, you could consider changing them to a pleuronine. And then the cautions for these, similar to the previous ones, mainly hyperkalemia or significant renal dysfunction. If your patient has a little bit of hyperkalemia after starting spironolactone, but it's up to 5.5, I think it's reasonable to continue. But if it starts to cross sort of 5.5, then I think you need to stop that, and just be cautious about your renal function, and make sure that you check your use and ease after starting these tablets. And then the new kid on the block, I said dapagliflozin, empagliflozin. The two pioneering heart failure trials were DAPA-HF and EMPEROR-reduced. To be honest, we still don't know why they work in heart failure. These were traditionally diabetes medications, and we found that they help patients with heart failure who don't have diabetes. How they work might be sort of beneficial effects on myocardial metabolism, reducing inflammation and fibrosis, improving endothelial function, vascular function. And although we do know that they cause weight loss, reduced congestion, improve natriuresis, and reduce blood pressure, we can't say that this is for sure why they're improving outcomes, because the tablets that do that don't have the effects that these tablets do. Like I say, sometimes if you start somebody on dapagliflozin, for example, because of the congestion relieving effects, you can actually be able to reduce the amount of diuretic that you give someone, and that can be quite helpful if, for example, you're struggling with blood pressure, or struggling with other symptoms and signs. When you give somebody, or you want to prescribe an SGLT2 inhibitor, you need to think about the contraindications, and the usual ones apply, like an allergy, pregnancy, GFR less than 20. So that's lower. So that's a lower GFR compared to the other tablets, which you would start at less than 30. So this is less than 20. So you can actually start it at a lower kidney function. Hypotension. So these tablets do cause hypotension, and the other thing to mention is when you start patients on these tablets, you need to counsel them on the effects of glycosuria, because the way these tablets work, they excrete glucose in your urine, and that can predispose to genitourinary infections. So you need to counsel these patients on these effects, and also tell them that if they do feel unwell, they should stop taking these tablets. They're called sick day rules, and then restart the tablets after that. There are other treatments available in patients with heart failure reduced ejection fraction. You may have heard of some of these. One of them is called ivabradine. This tablet should be considered in patients who are only in sinus rhythm, so you shouldn't give these to patients who aren't in sinus rhythm. And if they have a heart rate more than 70, and despite optimal medical therapy, they're still symptomatic, you should consider that. They're also a good alternative to patients who can't take beta blockers, so that's something to think about. Vericiguat is also a new soluble GCP stimulator, so that can be considered as class 2 level of evidence in patients with NYHA class 2 to 4 heart failure, despite optimal medical therapy. You might have heard of hydralazine nitrate as another option. Usually it's identified to work better in Black individuals. So that's something that you can consider if patients are intolerant to ACE inhibitors or ARNIs because of, for example, abnormal renal function or end-stage renal failure. That's something that can be considered. And then don't forget digoxin is also a treatment for heart failure patients as well. Another thing that I think is worth mentioning before we wrap up is checking and screening for anemia and iron deficiency in patients with heart failure. The Ironman study, which was conducted in 2020 or published in 2022 in the Lancet, shows that patients who are iron deficient benefit from IV iron supplementation. So it's important to check that, screen for these patients, check their iron status when they're in hospital, and then consider giving them IV iron infusions, either when they're in hospital or on discharge. So this is just a sort of a summary of what we've discussed today. The other thing that is important to discuss, which I haven't mentioned, is complex devices. So obviously that's not strictly pharmacological, management of patients with HFrEF, but something that you should think about. So patients who have, despite optimal medical therapy, have an ejection fraction that's reduced, and if they have left bundle branch block, so more than 150 milliseconds, and they have an ischemic etiology to their heart failure, you should be thinking about things like CRT-Ds, so defibrillator, or P for pacing devices. And even in those who have non-ischemic etiologies, you can also consider device therapy or CRT-P or ICD, depending on how long their QRS duration is. If that's just the summary again of what we talked about, so when to consider complex devices in these patients if they've continued to have optimal medical therapy. And I think Joseph's just messaged me to say we've got 5 minutes left, so I'll just pause at this point to see if anybody has any questions that they'd like to ask. I'll stop sharing my screen. I'm not sure I know how to stop sharing.